So we're going to talk about how to deal with problems and challenges in vascular access. We're going to not talk about too much about options in terms of tunneled lines, ports, that kind of thing, but I'm happy to answer questions about that. But what seems to be most challenging much of the time when I get calls are, my device isn't working, or, I have repeated infections, or I can't find a practice that will deal with or help me with limited access. Okay. So when I go introduce myself to people who are referred to me, the first thing I do is explain what interventional radiology is. I just say, well, what that means is we're the people who deal with challenging vascular access and deal with problems with lines if the patient is referred to us for a line problem. But overall, all our work is guided by minimally invasive procedures and the use of different imaging modalities to do what we do, whether that's a biopsy or a drainage or an ablation of a tumor, whatever. And we use all different kinds of modalities. For vascular access, it's primarily ultrasound and fluoroscopy. Fluoroscopy is basically like a video version of a picture of a plain X-ray. It's live and we can see things in real time. CT is not a modality we use very much for vascular access, except when we do what's called a CTV, and that's a CT venogram. And we'll do that to map veins. We're going to talk about that in a little bit. MR, because it involves magnets and we use a lot of things that are metal, like needles, is not a modality that we currently use for access. So what does that mean for access? We use ultrasound, fluoro, and sometimes CT to put devices in to assess problems with functionality. For example, withdrawal occlusion. You can't get a blood return, but you can flush, you can infuse, or maybe you're getting high pressure alarms from your pump or resistance to infusion. We also use imaging to do what we call vein mapping. And that's a really important concept for everybody to understand. And what that means is an assessment of the location, the patency, which means is the vein open, and how the caliber, the quality of those veins, how big is it? Is the flow free flowing through there? That kind of thing. So sometimes it's just that if you've had a lot of access devices, the vein just isn't open anymore. It's clotted off, or it has what we call stenosis. And what stenosis means is it's scarred down. So where normally, the vein might have been the size of your thumb, now it's just a thread because of scarring. We also use all these modalities to treat these problems if we need to bust up some clots. Thrombus is another name for clot, or try to deal with those stenosis or narrowing. We do that with a balloon. I'm going to show you some pictures of that in just a second. So here's what ultrasound looks like. And this is one of our interventional radiology suites. And in the left-hand portion of the picture is my hand. And then there's the ultrasound transducer. That's the thing on the cord that transmits the image to our screen. So here's the collarbone right here, and we're going to lay that transducer right down there because we want that puncture into that vein to be nice and low. That's going to make it a lot more comfortable for you rather than having something high up in the neck where every time you move your neck, it's going to annoy the heck out of you. Unfortunately, it's common to have a line placed high in the neck in ICUs for a plethora of reasons. So here's our ultrasound image over here. And I think it's a little hard to appreciate, but you can see this dark, big circle there. And then this lighter gray around it. And so that dark circle is the internal jugular vein. And that's that big vein. You have one on the left, one on the right. And that's going to be our sort of go-to vein. And that's because it's a pretty good size. And it's also a pretty straight shot, especially from the right, to get to where we want to go. And here's a better picture of it. So right here, this big one on the left-hand side is the internal jugular vein, and it should look just like this, sort of nice and fat and juicy. And you don't see any of this light gray in it. If you saw that, that would be clot. And right here, this little one to the right of the big one is the carotid artery. And that's the typical presentation that we'll see. So how do we know, no matter where we come from, how do we get the tip of your catheter in the right place? So I tell people all the time, it doesn't really matter where you start. What matters is getting it in the right place. So the importance of that to you is that you have a lot of choices and input into where that catheter or port comes out of your body. Okay, it doesn't have to be just in one spot. That we can make it longer, shorter, whatever on the outside of your body so that it makes it easier for you to manage hooking up and doing dressing changes and things like that. But here's where we want to be. You can see it again, it's a lot of detail, but here's this little skinny white line coming through here and ending right here. Okay, so when you look at any of these pictures, it's like looking at yourself in the mirror. So this is the patient's right side, this is the patient's left. So it's like a mirror image, it's reversed, and sometimes that gets confusing. So this little line here is coming up from the left arm, and you see the end of it right here, and that is what we call the atrio-caval junction, which means the big vein, big fat vein here, which you can't really see, and I'll explain why in just a few minutes. But there's a big fat vein here that we want to go through, and that's called the SVC, or superior vena cava. And then we want it to land just where this vein ends and the right atrium, or the beginning of your heart, starts. So what we do is we use anatomic landmarks to approximate where that goes. So right here and right here are the bronchus, left and right. So that's how I know where, when I'm here, I go just below that junction. But basically I use fluoroscopy, which again is that video kind of x-ray thing to figure out where I'm going to go. And I can do that in real time. If the line is placed at the bedside or in an urgent situation, that's typically in an ICU kind of situation, and then they'll get an x-ray and figure out where it is. The problem with plain x-ray is you might have to make an adjustment. You might get that picture and say, ugh, I really want to be, 2 centimeters deeper or 2 centimeters shorter. And then you have to make that adjustment. The other way to figure out where you're going is with what's called ECG Tip Location Technology. And that's when we put a line in that's got a little sensor in the line. This is FDA approved for both PICCs and ports. It's interesting that it's not approved yet for tunneled catheters like Hickman's and Broviac's and things like that, but that'll be coming, I think, very shortly. So what that does is it has a sensor that looks at the waveform in relation to the beat of your heart to tell the person who's putting it in that they're in the right place. So why does that matter? That matters because it means that lines can really be put in almost any place, right? You don't need this big fancy interventional radiology suite that I've got. You could say, well, this could be put in a procedure room in a clinic or an office, or how about the home, right? So it's not been as much of a game changer in terms of changing how practice is done, except for PICC insertions, but I think it's something to pay attention to. It will not give us any information about scarred veins, caliber of veins, or anything like that, only that our tip is right here and then we're in the right place. So here's a better picture of a line coming in. So here's one coming in from here. There's another one from here. And you don't really see the overlay on those too much because they're running right next to each other. But this is a patient who's got some calcification of the main stem bronchus, which is here to here. That sort of looks like a pipeline kind of thing. And then over here is the right main stem bronchus. And over here is the left. So what we're doing is using these anatomic landmarks to estimate where our catheter tip position should be. And this is a perfectly placed line. You can see the end of the catheter right here, the tip right below the right main stem bronchus, and that's where we want to be. So can you tell exactly where that superior vena cava ends and the right atrium begins? You can't. But that said, we put a catheter in, and it's not in any patient like we have to be in, say, 17 centimeters. It's probably a landing zone that's between maybe 16 and 20 or something like that. Also, keep in mind that when you move, whoops, sorry, let me go back here a little bit. When you move, you raise your hands, then the tip is going to look a little lower. People all the time will get notification that their tip it may be too deep when they have a CT scan for another reason. Maybe there's something going on in your chest you have to look at. And when you're laying in the CT scanner, your arms are up like this, and that artificially sort of makes the catheter look like it's too long. And then the minute you put your arms down, it'll be correct. So all the time I get calls about that and just say, no, don't worry about it. When your hands are down, like that's where the tip resides most of the time. But that tip is a little bit mobile when you breathe and when you do things like move your arms. So here's a more exacting picture, and this is a venogram. So what a venogram means is we're injecting dye into the veins to exactly map them out. So you need some kind of device in place in your vein to do this, because you've got to inject that dye. So dye and contrast are the same thing. So again, this is the left subclavian vein. So this dye is being injected in the lower part of the arm, and we're using fluoroscopy, again, that video kind of picture, to watch how the dye moves. So here we go. Up through here. Now that looks like a little bit of a curlicue, right? But that's not. The internal jugular vein on the left is coming in here. So that's why you see it looks sort of light here and then a little bit darker, or what looks like a curlicue. It's not. It's just that one vein is meeting another. Coming across here, this is called the brachiocephalic vein, also known as the innominate. Again, a little bit dark because there's another vein entering here. And here's that thing we were talking about, the SVC, or superior vena cava, that sort of looks like a windsock. And here's where it joins the right atrium, mixes, and goes out to the pulmonary artery. Okay, so this is still a vein. It's just called the pulmonary artery. So it's going to come left arm down into the superior vena cava and through the heart and over to the lungs. Okay, these things here that look like little bow ties, those are sternal wires. So this patient has had some kind of open chest surgery, like a coronary artery bypass graft or something like that. And that's why you're seeing that hardware, because that's radio opaque. But here's a better representation of what the anatomy really looks like. Here's an example of an X-ray verification. This is a hemodialysis catheter, and that would be fairly obvious because you can see how fat this catheter is as compared to some others that we've looked at already. And you just need a fat catheter to do the job for dialysis. So you can see this nice wide curve on the catheter, and then the catheter tip right here. Okay, so that's perfect. I'm a little free on the mouse here. So that's exactly what you want it to look like, because it's got that nice wide curve, and that's going to mean that the flow through the catheter is unimpeded, and your performance on your device is going to be better. If you had a really peaked look here or a tight turn, then that's going to be a problem. This is just a snap on the patient's gown. That's all that is. Okay, so here's another approach. What if you have had a ton of lines and somebody's telling you, oh, your veins are getting scarred. We're not sure we can, you have anything left. Well, first of all, if somebody tells you you may not have anything left, you make them prove it. Okay. And that's, I get referrals from people from all over the place. And I say, how do you know? Like, what did they tell you? How do you know that there's quote unquote nothing left? So don't believe people unless they prove it to you. And honestly, in, 25 years of doing this, I have never encountered a patient who has nothing left. Might need to be more creative, might need to, do something really unusual, but it's very rarely nothing left. So in this case, these are just all EKG leads and everything, but here's your catheter coming up here and up. So this sort of thing that looks like a water balloon here is the heart, but the catheter looks upside down, right? So instead of coming from any of the veins in the neck and the chest, what we're doing is going through the liver into what's called the inferior vena cava, which is the lower portion of that big vein that's in your belly, and then up, right? So it's just a different approach that you use when the veins in the neck and the chest aren't usable anymore. So you want to be interacting with a group if you're in a tight situation that really pays attention to options and is willing to sort of be brave and creative. Okay, so what is a vein map? That looks like that venogram that we showed a few minutes ago, and it's basically a road map. So if you're in a situation where you're worried about, oh my gosh, do I have any veins left, or where are we going to go? I don't know if we can go here or there. Then talk to your clinicians about vein mapping. So we can do that by injecting dye, but a more efficient way to do it is what's called a CTV, or a CT venogram, because you only need one access to inject dye, and then we can map out as far as we want to go. So typically I'll order a CTV from the base of the skull through the pelvis, because I want to know where everything is. I don't want to just know what's in the chest. I want to know what are all our options. And we'll be able to watch that dye go everywhere and see what's available. So that line that just looked sort of upside down, we'll know if that's available to us. We'll know how big the veins are, whether they're open, whether there's any clot, etc. If you have not had many lines and there's a concern about patency, an ultrasound is just fine. It's a non-invasive way to look at veins, and you don't have to use any contrast. If you are allergic to contrast, we can do one of two things. We can either pre-medicate you with steroids to manage that, or we can use a different kind of contrast. And one is called gadolinium, which is what we typically use in MR. So being allergic to one kind of contrast, like the kind in CT, doesn't mean we can't do detailed vein mapping. So here's an example of a patient who had very little left in the neck and chest. And so we went in a collateral vein right here up in the neck. She had had lines for TPN for many, many, many years. And you can see this, here's the superior vena cava, but you can see it sort of dead ends right here, right? So that's not open anymore. You should see it come all the way down the heart like this, but you see it sort of make that turn. I always think that this looks like an elephant trunk. Sorry. So this is called the azygos vein. And what we did is we put her port through that. And the reason we could do that is because this azygos vein sort of got fat. Normally it's not that big, but it becomes big when the SVC or a neighboring vein is scarred down. So the way I explain this to folks is to say, let's just say you're on I-95 from New York to Florida, right? You should be able to, boom, go right down to Florida. But all of a sudden there's a wreck on 95 and the traffic is slowed down, you can't get through, then you go the side roads, right? And so that's exactly what veins do, is they say, all right, we got to get this blood back to the heart. We're going to go the side roads. So this is azygos. So here's the portal body. It comes up. We're in a little collateral vein, which is a vein that typically we don't use, but it's just one that gets a little bigger when the veins near it are scarred, just like the highway kind of thing. And then we go through here, loop around, and here's our catheter tip. Okay, so most people would look at this on an X-ray and go, well, who really messed that up? Like, somebody really did a bad job. Nope, this line lasted for, I think, about 5 years. So you can just do weird things like that. You just need a clinician who's willing to think outside the box a little bit. Here's a patient that we went through the liver. This is CT imaging. So on CT imaging, right, it looks sort of like there's a lot going on here. So think of this as looking at a piece of salami and you're looking down the end. So here's these two dark black circles are lung. These are the scapulas. This is the spine. And this is an internal jugular vein. And this is in a young woman who, like, everybody said, you have nothing, you have nothing. And so we did that CTV. And then we followed that funky vein there and went down here. And here's her line. Again, people would look at this and go, what is this, like, reverse candy cane kind of thing you got going here? But because we had this roadmap with this dye like this, we could just follow it down and get her a line that worked. Now, this is a line that's probably, not going to work for 5 or 10 years, but we needed to get her to an intestinal transplant. And so it lasted long enough to do that. And then she didn't need to be on home TPN. Here's an example of injection of dye through a catheter. So here you see the catheter, okay? And then you see what should be a straight, sort of darker look at contrast, but you see it's sort of murky looking, right? Here's this darker contrast, and then here you see like these areas that look a lot lighter. And so this is, I don't know why that keeps happening, Reed. This is clot that's stuck around the catheter. So this dark part is the dye coming through, and then you see all this stuff here that's lighter. And on the report, it'll call that a filling defect. And that just means clot that's taking up that space that the dye can't get into. And that's how you know that that's clot. Here's a fibrin sheath. So this is just sort of gunk that's stuck around the catheter because your body says, hey, what's that thing? I don't love that tube that you've stuck in my vein. And it's just this fibrous kind of stuff. It's not clot, it's different. It's this like filmy, but sort of tough, junky kind of substance that your body lays over catheters. And the problem is, right, it sticks to the catheter and then it can get in the end of the catheter like this. And this is a classic situation when you can infuse, but you can't withdraw. And we can treat this with TPA, either single dose lock or an infusion, or we can even sort of take a thing that's like a lasso and pull this off. One of the main problems with both clot and fibrin sheath is that they're associated with line infection because bacteria love to sort of sit there and hide. Here's an example of what a fibrin sheath looks like on a ultrasound after the catheter is taken out. So that gunk that we just saw stuck on those catheters, sometimes it stays behind. We take out the catheter and that stuff doesn't necessarily stay with the catheter and come out as we pull it out. It sits there in the vein and stays there. And then the next time you need a line, we can see that. Okay. Here's another example of a catheter coming through. We injected dye through another site, but here's the catheter. You can see it's got these sort of loops in it, which isn't fantastic, but here's a big fat vein, and see how it goes down to just this little teeny thing. It's sort of like taking a 5-lane highway to a 1-lane highway. And that's what's called a stenosis or scarred area. And what we can do is get a balloon in there. We have a little bit of dye in the balloon and we can sort of bust that open again. And here's an example of what that looks like. This is a different site, but we've got a guide wire coming through here, and then we have the balloon. And once we get to the spot we want, we inflate the balloon and we can see that we're in the right spot, because you see, this should just sort of look like a hot dog or a sausage, but you can see it's got this indentation here and here. And that lets us know we're in the right spot to treat the scar. And so we put a little more pressure on that balloon and that opens that up so we can get better flow in that vein again, and then put a device through it. If needed, we can put a stent in. So you can see here's the stent from here to here. It's almost as if you took a piece of screen off your window and cut a little piece of it and rolled it like a Chinese finger trap. And then that provides some scaffolding essentially, or support to keep that vein open. And then we run our line right through the middle of it. So these are all things that can be done if needed. We can get through areas that are occluded with what's called a radio frequency wire, which is sort of a heat source on the end of a catheter, and just sort of burn through the, an occlusion. I always think of this as sort of like how we built subways in New York City, where you had that thing that sort of burrows through the ground. This is a pretty advanced technique, and you need to be in experienced hands to do this, because this is a heat source here. You can burn through something really easily and not be in the vein and then get into trouble. So those are all sort of, you know, slick, creative options that a lot of people in the United States know how to do. And depending upon where you live, I can tell you like who's really good at this, or, you know, get you connected to someplace if you need them. But my advice to you is to really know what you want, you know, to understand as much as you can what you've got available for target veins. Like, get all your reports, right? Ask the medical libraries at the places that have, or film libraries that have treated you for those reports. A lot of systems have this thing called My Health, and you may be used to communicating with your providers through that, but typically they don't link to surgical or radiology reports, but you can request them, okay? One of the things we need to know from you is, do you have other devices? For example, do you have a pacemaker, a defibrillator, anything else like that in the area? I did a patient the other day who had a big hunk of hardware in their clavicle from a trauma event, and, you know, things like that we need to work around. If, to the best of your ability, tell us, oh, okay, I've had, you know, 3 ports, every single one of them I lost for infection, you know, that kind of thing. So we can sit down and talk together and figure out, all right, losing 5 ports to infection, that's really a lot. What do we need to do differently? The other thing that's helpful is for you to tell us, you know, look at, what do you want? Do you want a port because you don't want something hanging out all the time, and maybe you only need to infuse 3 times a week and the rest of the time you want to not deal with it? You don't want somebody telling you, oh no, a port's not appropriate for a TPN, or oh no, a port's not appropriate for home. You know what? One size doesn't fit all. So talk to us about, hey, look, I like to swim, or I do gymnastics, or whatever I like to do. So this is the device I prefer. This is why. Our job is to educate you. And so you know what your choices are and what the pros and cons of every device are. Tell us where you want it. Maybe you want it left, right, whatever. Normally, we'll really advise you to stay on the right side if we're going to start your line from the right neck, because it's a short, straight shot. But you may have a compelling reason to say, look, I really need to go on the left because of my occupation or whatever it is. You may say, look, I just don't want to deal with maintenance. So let's talk about a device that will give you the least maintenance that's possible. Okay, so just be totally level and straightforward with us, and you should have a provider who listens to that. If you don't, get another provider. We can put your exit site anywhere. We talked about the tip location, but here's a lady who, for many reasons, ended up with her port on her back. So we're still on the left, and then here you follow the line and up and over. Now, this was after the port was only about 3 days old, so you can still see the glue on her skin and the suture line. Of course, this looked way better in 2 weeks. And here's the septum on the port. If you were going to access yourself for home TPN, this would not work well, unless you had somebody in your family who was the person who was going to access your port, and then it's just fine. Nothing wrong with this. A lot of people like this better because they don't have a line in the anterior chest, easier to hide, sometimes a little more comfortable, and certainly super easy to secure a dressing on there. How about a tunneled catheter in the arm? So many of you may have had PICCs. This is a power line, which is akin to a Hickman or a Broviac. It's just polyurethane. So the puncture site is here, and the catheter comes out here. So you've got a tunnel here and a cuff. And this was a gentleman who was a horse farmer, and he's just like, I just don't want anything in my chest. And I think he had this for about 7 years, loved it. It was very stable. He did great with it. This is a line in the thigh. So here's a port. Here's the groin, or the crease where the leg meets the body here. And so we brought the port down to the lateral or outside of the thigh. If you have to have a line via the groin, or it's called the common femoral vein, you want to make sure your exit site is quite a bit away from there, because it's higher risk of infection to go up near the groin. It's just warmer, moister, the whole bit. This is a little trickier to do with a tunnel catheter. I personally would strongly advise against having a tunnel catheter that comes out the thigh, because the ends of the lines are just dangling, then they're going to get in your way. But what we can do is go into the common femoral vein up here and then go upside down. So we turn it around and bring it up your belly so that it's easy to secure on your belly. And it does have a loop, but that's okay. It'll still work. So we discussed this just a little bit, but I would say, don't think that you have to go to anybody. You don't. I know there are sometimes limits with insurance, but go to somebody who's going to listen to you and who's going to be creative and discuss options. Meet with them ahead of time. Pretty much all of us have an office, or at least someone you can talk to and say, hey, can we discuss pros and cons? You can do that over a video visit, which you've probably done with other providers. The other thing in a vascular access practice is you want somebody who's going to deal with problems afterwards. You don't want a group where maybe you have a dysfunction problem or an infection concern, and they're like, well, just come to the ED. Well, no, no, work with me here and manage this, because stuff happens. Okay. If you have any questions, you can get me here. You could also call Reed, and he'll connect me with you to answer different questions and help you through this whole process. Another important point is just to think long-term vessel preservation. You don't want lines going in and out all the time. We were all born with a certain number of veins, and we don't make any new ones. So keep, to the best of your ability, the veins that you have. We should keep using the same vein over and over and over until it's not usable anymore, not, switch around left to right and here to there. Okay. Can I, let's see, we're going to do questions. Is that right at the end?
After.
Okay. Okay. After.